As parents or professionals, most of us have been involved in the autism diagnosis process at least once. But do we really know how autism is actually diagnosed? And what does the testing process really look like? Hi, I'm Dr. Mary Barbera, autism mom, board certified behavior analyst, online course creator, and best-selling author of The Verbal Behavior Approach. Each week, I provide you with some of my ideas about turning autism around. So if you haven't subscribed to my YouTube channel, you can do that now. Today, I'm sharing a small excerpt from a recent podcast episode with developmental pediatrician Dr. James Coplan, where he gives us insight on how autism is diagnosed and what treatment he usually recommends.
I'm sure you, in your vast experience, you've had many parents where they really want to pinpoint where the child's at, and that's a very slippery slope, right?
And in fact, what I've said to people is, I can give you a map of the territory, or it's like a chart of the harbor, maybe, but there's fog out there. I know there's an island here, pardon me, there's a riptide over here and rocks over here, but because it's foggy out there, I can't tell you exactly where your child's boat is at the moment. There is this territory, there are these hazards, there is this ship's channel, but it would be unfair to your child, for me, on the basis of an hour in the room with him, to give you a prediction with that degree of precision. Now, let me back up for a second. Excuse me. One of the differences between psychological testing that Geraldine Radcliffe did and the way I arrive at a diagnosis, and I respect this, and it's like there are different ways to get somewhere. Psychologists put a lot of value, and correctly so, on what they can test in the room and demonstrate in the room. Whereas as a physician, what I'm taught is a lot of the times you make the diagnosis based on the history. So if parents come in and they say to me, my child doesn't do this, he does do this, he doesn't do this, he does do that, I attach a huge amount of weight to that, and I'll try to do some testing at the table, but basically or predominantly, well, maybe not basically or predominantly, but to a larger degree, my diagnostic impression is going to be formed in at least equal parts by what I see and what I hear, unless there's a disconnect between those two things. If the parents say, oh, he doesn't do X, but he does, or he does X, Y, Z, but I can't get him to. But when they align, it's like two legs of a stool. But I'm going to put a lot more weight on the history, whereas psychologists, by the nature of their training and by design, they're going to give Bailey scales of infant development, or they're going to give ADOS, or they're going to give whatever, and they're going to go much more by the numbers on that piece of paper. And those may be discrepant, and it doesn't mean one person is right and one person is wrong. What it means is we came to our diagnostic impressions using different subsets of the universe of data. Now, and again, but let me come back to your larger point. On that first day, when the kid doesn't even understand that he's being tested and that his job is to do his best for this strange adult that he's never met before, it's not fair, it's not professional on my part to conclude that he couldn't do X. All I can say is he didn't do X. I can't say, and this is another mistake that teachers make, it's another mistake school psychologists make. I don't think behavioral psychologists make it, but school psychologists and teachers will say, he refused to do X in class, when what you need to say is he didn't do X in class. Or put it on yourself and say, I was unable to get him to do X in class, rather than impute willful task refusal to the child. So on day one, if the kid doesn't understand what's the game that's being played here, and my job is to jump through Dr. Coplan's hoops, I can't make a conclusion from that. On the flip side of that, if by sheer luck that day he puts the pretzel on the plate and gets points, good for him. I'm not going to take it away from him. But so there were discrepant answers, but I think the professional answer is to say, what we need to give you today is knowledge of what you need to do tonight and tomorrow. And anybody who claims that they can predict 5 years from now is really blowing smoke, because that technology or those skills really aren't there. And to hold on to your wallet when somebody tries to take that line with you.
Yeah. So I remember, when you gave the diagnosis, like I said, you recommended ABA, Applied Behavior Analysis Program. And I know many years have gone by, 2 decades since you diagnosed Lucas, and you've
We're
been,
not any older, by the way. We're not any older, just Lucas, right?
and so I know you retired from clinical practice 5 years ago, but within the past, when you were practicing the past 15 years, did you continue to recommend intensive ABA programs, or did that depend on the child? And what level of ABA programming did you usually recommend for a child with
Right.
moderate severe autism?
Okay, so you put in the qualifier moderate to severe autism kind of at the end of your discussion, but I would see kids at 16. I had a child referred to me at 16 for, quote, a reading disability because he couldn't understand the social content of stories. It was not a reading problem at all. It was a theory of mind problem, and I don't think that kid would have needed ABA. He needed social stories and insight-based intervention. But for somebody who there's an old Kentucky recipe for rabbit stew, and I used to say this in the office also, okay? Maybe I never said it to you. There's an old Kentucky recipe for rabbit stew, and the first line of the recipe says, first, catch a rabbit. And at the very beginning, the object is to get the child to come, sit, attend, reciprocate, and that's like catching the rabbit. And then once you have that basic skill set imparted, then you can use that skill set to impart more complex skills: reciprocity, self-care, communication, the fact that when I say milk, that person out there is going to give me the milk, which they might not learn through incidental learning. Kids without spectrum disorder are great at incidental learning. They do something once by accident and they catch on right away. You never have to teach them again. So, wow, where did he learn that? Kids on the spectrum often need explicit, they need explicit learning, but until the kid is sitting at the table and attending, and he knows now what the game is that's being played, and it's not a game, although you make it game-like to engage the kid, the object of this is for me to acquire a new skill set. And the child may not say that to themselves. They don't internally verbalize it, but definitely ABA is a really proven, time-tested, proven way of imparting new skills to somebody who may not be available to social learning or trying to appeal to verbal inducement of some other kind. So I continue to endorse ABA in that kind of situation, absolutely.
I hope you enjoyed this short snippet from the podcast. If you want more content, check out the podcast at marybarbera.com/podcast. Wherever you're watching this, I'd love it if you would leave me a comment, give me a thumbs up, share this video with others who may benefit. And for more information, you can attend a free online workshop at marybarbera.com/workshop. And I'll see you right here next week.